What's up everybody? Dr. Rossi, StrengthsAndSneakers.com. So I'm going to continue my video series where I try to explain to you guys what kind of thought process goes into making a decision on selecting a SSRI, selective serotonin reuptake inhibitor medication when you're treating somebody's depression. Now, if you haven't seen part 1 of the series, I suggest you start there, and that's just because that kind of lays the groundwork for what we're going to be discussing and gives you some overview of these medications in general. So start there and come back to this video. But if you've already seen that part, then let's just jump right into it. And today I'm going to talk specifically about Escitalopram and Citalopram. So these are actually kind of the same medication, and I'll explain why. So Citalopram is a 50-50 mixture of the R and S isomers. Escitalopram is just the purified S isomer. So the medication or pharmaceutical companies are very smart because they said, well, we know that the S isomer is 166 times more potent than the R isomer, indicating that the real efficacy of citalopram comes from the S isomer. We are going to just purify that S isomer and create a new medication. So that's what they did, and that's how we got Escitalopram, with the S portion standing for the S isomer. Now, there's a few main benefits of these medications, and the two things that come to mind for me when I'm thinking about selecting this medication for a patient is that, one, there's a relative lack of drug interactions, and I'm going to explain more about that in a second. So there's virtually, I don't want to say no, but there's way less drug interactions than some of the other selective serotonin reuptake inhibitors. And the second point is, if you're looking for a medication that is highly selective for the serotonin transporter, this is it. So this is the most selective for inhibition of the serotonin transporter. Now, these medications are the only two SSRIs that do not inhibit or induce CYP or CYP450 enzymes in your liver. And this is important. So the medications are going to have a lack of drug interactions because they're not inhibiting or inducing that CYP450 enzyme system in your liver. Now, this may actually explain why both citalopram and escitalopram actually have the best evidence when used in combination with bupropion. So when you're augmenting with bupropion, it seems like escitalopram and citalopram from the literature is a much better option than some of the other SSRIs. And the reason behind that is these SSRIs interact with bupropion. So the other medications interact with bupropion. However, there is one deal breaker with citalopram, and I think this is an important point that everyone should be aware of. It's the SSRI with the highest risk for QTC prolongation. You might say to me, Dr. Rossi, what the hell is QTC prolongation and why do I care? Well, QTC is an interval that's measured on your EKG, electrocardiograms, and that's can cause, if it's prolonged, and if it's prolonged significantly, can cause an arrhythmia called torsades. So you want to avoid that at all costs because it can be life-threatening. But you might be saying then, well, who is the population that we're going to worry about that in? Well, we're obviously going to worry about an arrhythmia in elderly population, so older patients, geriatric patients. We're also going to worry about it in people with a significant history of cardiac disease of any type. So we want to watch out for that. Now, escitalopram actually has the second highest risk for QTC prolongation, but it's a much better option than citalopram and has a lower risk than citalopram for QTC prolongation. Another important point here is that the risk goes up when a patient is taking a CYP2C19 inhibitor. So the reason behind that is citalopram and escitalopram are metabolized by two of these CYP450 enzymes. So specifically CYP3A4 and CYP2C19. So if you inhibit 2C19, you're going to increase the amount of citalopram or escitalopram in your body, and then that's going to put you at risk for more side effects and possibly toxicity and other complications. And that's also going to increase the risk of QTC, because with citalopram it's dose dependent. So the QTC risk is dose dependent. So obviously you don't want to inhibit that enzyme that's breaking down this medication. What that translates to clinically when we're thinking about it is that we have to limit the amount of medication we deliver to somebody who is over the age of 60, who's on a cytochrome P450 2C19 inhibitor, or who is a known poor metabolizer, meaning they had genetic testing of their CYP450 enzymes, known poor metabolizer of 2C19. So for those patients, we have to limit the dose to 20 milligrams per day, which means that their depression may not be effectively treated. So there's a limit in terms of how much medication we can administer to people who are over the age of 60 on a 2C19 inhibitor or a known poor metabolizer. So that's what makes citalopram less of an option here, and why I personally prefer to use escitalopram in most of my cases. Now, you can switch somebody. Say you have a patient who is over the age of 60 and you want to switch them from citalopram to escitalopram. There is a rough guideline. What you can do is you can take the dose that they're on of citalopram and divide by 3, and that will give you the new dose for escitalopram. So let's take an example, make it really simple. Let's say the person is on 60 milligrams of citalopram. They're doing pretty well on it. Their depression is well controlled. You want to keep them on a similar medication. You decide to switch to escitalopram. You divide by 3 and you come out with a dose of 20 milligrams per day of escitalopram. So that's how you would do your conversion. Now, besides this medication being safer, escitalopram being safer in the elderly, it's also approved to treat depression in the pediatric population. So for children 12 years and older, they can also use escitalopram there, and it is very commonly used in the child adolescent psychiatric clinics. Now, there are 5 head-to-head trials that may indicate escitalopram is a little more effective than some of the other SSRIs, but those benefits are very minimal. So again, I said most of these are about, the efficacy is about the same when you're thinking about which one to choose. So we're making the choice based on these other factors. So hopefully I explained some of the other factors that might go into making a decision to choose citalopram or escitalopram, specifically more likely escitalopram, over another SSRI. So thinking about an elderly patient, thinking about anyone with cardiovascular disease, thinking about anyone who's on a lot of other medications. And if you have a pediatric population of 12 years and older, you may consider this medication for the treatment of depression. So I'm going to hold the video there. If you guys have questions or comments, please drop them below. I'm happy to do my best to answer them as fast as possible. And please like and subscribe to the channel. It helps me to continue making these videos.